Good evening, everyone. I am Arpita from the IGCP group, and I welcome you all to a new webinar on the topic Case Based Insight into Congenital Heart Disease. And yes, to address the topic, we have with us someone very eminent from the field of pediatric cardiology, none other than Dr. Ivy Vijayalashmi ma'am, who is known to everyone. Still, a bit of introduction to start with the session. She has done MD, DM, DSc, FICC, FIAMS, FIAE, FCSI, FICP, FAMS, FISH, and FRCP from London. She is Professor Emeritus, former HOD of Pediatric Cardiology at Sri Jayadeva Institute of Cardiovascular Science and Research at Bengaluru, India. So, ma'am, with this introduction, now I would request you to please start with your presentation and post that we'll take questions from the audience. Over to you, ma'am.
Yeah, good evening, everybody. It's a pleasure to be here again at IJCP. And I'm going to show you some interesting cases how to manage the congenital heart diseases today. The diagnosis of congenital heart diseases represents the epitome of applied clinical logic. When correct inferences are drawn from the accurate observations, the diagnoses are made with a gratifying frequency. That's what Joseph Parloff said. And I read the clinical recognition of congenital heart disease written by him not once, twice, thrice when I was a postgraduate. But later on, when I wrote the comprehensive approach to congenital heart disease, he was the first one to write the preface for that book. And this is how the clinical practice started. Inspection, palpation, auscultation, and contemplation was what Sir William Osler practiced. But today, we have X-ray, ECG, echo, CT, angio, and whatnot. But still, we lag behind in making the accurate diagnosis. The technology of echocardiography has grown by leaps and bounds, and today it has almost replaced the angiography in many cases. And look at this 3-day-old baby came with the pustule in the arm, and then the legs were swollen, and the child was in septicemic shock. When I did the echo, you can see that there is a mass in the intraatrial septum exactly where the fossa ovalis or the AST is there. And you can see that there is a vegetation in the IVC and also over the Comedian ridge. The Comedian ridge or the warfarin ridge, they used to mistake it for thrombus or vegetation in the past, and that's why it is called as. And so we made the diagnosis of intrauterine infection, and then we treated with the higher antibiotics. The child became all right. So this is how an AST or a PFO can cause a problem. But most of the time AST is missed, and the patient goes into the third, fourth, fifth uh, decade, and at that time they come with a complication. Like this 55 years old female complaints of breathlessness, exertional dyspnea, swelling of the legs, and episode of palpitation. And she came with a history of chest pain, and there was no history of chest pain. And somebody had done the echo and made the diagnosis of diabetic cardiomyopathy because she had a diabetes. But then when I auscultated, I saw that the second heart sound was widely split and fixed, and grade 2 by 6 short superficial ejection systolic murmur, which is the hallmark of AST, was there. So I knew clinically it is an AST, and ECG showed the tall R wave in V1, indicating already there is a pulmonary hypertension. When I did that echo, it was AST, and did a transesophageal echocardiography to measure. It was almost 30 millimeter AST, and I closed it with a 32 millimeter Amplatzer device. And this is the X-ray before, and that is after I closed. And today she's absolutely fine. Thanks to Kurt Amplatz, as you see in this picture, 30 years ago in 1997, he came out with the Amplatzer device, and this device is a self-centering and also self-expandable one. And you can see that through the AST, we go into the left atrium, pull it to the septum, and then release the retention skirt on either side and remove the screw in the anti-clockwise, and the device remains there, and then the AST is closed. But in the past, when we didn't have the 4D echo or the 3D echo, we used to have the residual AST, because the shape and the size cannot be accurately made out by the 2D echo. But today, the 4D echo is so excellent, you can see from the RA side or the LA side. This I'm showing you from the RA side, and you can see the rim, it's a large AST where the yellow balloon is going. And not only that, in the past, this is the first animal study when they used to dissect, do the autopsy and see whether the endothelium has grown or not. But today, the 4D echo, when we do the follow up echo, we can see that the endothelium is beautifully grown over the whole device. And this is how you can see that there is no thrombus, no vegetation, nothing, and it is endothelialized. And this is how we know the beautifully the ASTs can be closed. And the first AST that I closed, and today she's a doctor. And in the past 30, 40 years ago, the doctors, the pediatricians were taught that there is a Rogers murmur. The murmur that you hear at birth, as the child grows, it will close. That is, they used to think that the small VST will close. But today, the echo has shown us that we should not neglect such, because subpulmonic VSTs, inlet VSTs, they will not close. So here is the patient, 52 years old man, presented with the palpitation since early childhood, fatigue, and then now he's in orthopnea, PND for the last 1 month. There is the swelling of the feet, and he had a to and fro murmur. That is, to murmur was due to the VST, and the fro murmur was due because of the aortic regurgitation. So here you can see that not only there is a VST, the VST is being tried to close by the prolapse of the cusp. So this is from my textbook, the diagram showing how the Venturi effect can suck the aortic cusp, causing the aortic regurgitation. What would have been like a simple VST closure, now patient had to undergo the valve replacement also. This is a 5 years old boy waiting for the spontaneous closure till 9 years, and in the bargain, he developed the severe, fever for past 3 weeks, and then he came with the vegetation. And this boy, 1.5 months treated as a bronchopneumonia because of the X-ray, and when the patient deteriorated, he was sent to me. And at that time, we saw that the patient had a small VST, but he was in CCF because of the bacterial endocarditis. So literally the vegetation was trying to close the small VST. So today the device closure is so handy that we don't allow these children to develop the bacterial endocarditis at all. So we treat them in time, and so that this problem of vegetation, especially in the right side of the heart, causing the tricuspid stenosis and regurgitation, all can be overcome by the device closure in time, and they do not require the SB prophylaxis once we do the device closure. This is a 1 month old baby, history of fever, chest retraction, feeding difficulties, suspected a right atrial myxoma. You can see that there is a huge vegetation, huge mass, but the myxoma is attached to the intraatrial septum, and this is attached to the tricuspid valve. So this is how you have to distinguish between the two. So here, the stormy neonatal period, the child was treated in the NICU, and the umbilical vessels were used for the access to give the antibiotic, and that's how IV drug abusers, the child had developed a vegetation on the tricuspid valve, and this is not a congenital heart disease, it is because of our problem. So here, this is another case. A 10 years old child had a VST, but it was not closed, and the parent did not bring, and child was not on the SP prophylaxis. And look at this, you can't even make out what it is. It is so shocking. And then what I did was, we were not able to see the heart, we were not able to see anything. I did the puncture from the zipisternum and slightly injected the dye in the pericardium. This was like partially organized pericardial effusion. Thick pus was there, and once the guide was wire was there, I put the pigtail and then introduced 10,000 intrauterine, intravenous streptokinase, and then drained 450 ml of fluid, which was very dark in color, almost hemorrhagic, and the vancomycin lavage was done, and then we saw that what was picture like this, and this is how at the end. So after the treatment with the bacterial endocarditis, the vegetation healed and the residual VST was closed later on. So this is how we have to see that even the small VST should be closed. This was a 3 years old child. He had a huge vegetation attached. It was not attached to the tricuspid valve. It was not attached to the intraatrial septum. So I was surprised, and this was a Garbude defect. So Garbude defect is the one where the LV is connected to the RA. So the VST is either directly through this perimembranous area or through the tricuspid valve. This is the type A and the type B. So whatever it is, in the past they used to think that it is just 4 millimeter, leave it. But after I lost that patient, I said, this is the end. No child should die. So then we started closing these garburations, and then with the device, and the best device is the ADO2, and they're very suitable for that. So this is how it was closed. So this is a 3 years old patient came with the fitness. You can see that there is a bicuspid aortic valve with a trivial AR. But to our utter shock, the patient had vegetation on the over the aorta, arch of the aorta. So whenever we have lower limb pulses are not felt, upper limb BP is very high, think of coarctation. The murmurs may not be heard. The murmur may be heard in the back, but then be Indian, touch the feet, you'll never miss the diagnosis of coarctation. Unfortunately, this 15 years old boy came with the atrial fibrillation, pulmonary edema, and he was a known case of rheumatic heart disease with the mitral stenosis. We took him for the emergency balloon dilatation. And the moment I felt the femoral pulse, they were not felt. I told my professor, sir, this is the coarctation. He said, if you can't puncture, come this way. I said, sir, I can puncture, I can do. So, as I guessed, pulse was not there. So, this is how the coarctation was there. And I crossed it with the guide wire, dilated with the balloon, got a good result. And then in the same sitting, we did the balloon dilatation of the mitral stenosis also. So, remember, in our country, both the congenital and the acquired can exist in the same patient. So this is a 40 days old neonate treated in a medical college as a dilated cardiomyopathy with the ionotropes. And my associate said, ma'am, I'm scared to push the cuff because the BP was 210, 220 by 110 in a newborn baby, and ejection fraction was 35. So we did the balloon dilatation, opened up the coarctation, LV function improved to 55, and BP dropped to 110 by 80. So coming to the aortic valve, the complications are only less than 5%, and today's success rate is very high. And we have then name it. This is the highest gradient that balloon dilatation I have done. The gradient was 242 millimeters across the aortic valve. You can see that the cusp separation less than 3 millimeter. And this is another patient who had achondroplasia, full-time pregnant, and then the anesthetists were not ready to give anesthesia because she had a aortic stenosis, bicuspid aortic valve with the stenosis. The gradient was 178. So both the obstetrician and myself, we donated the money for her balloon dilatation. We did in the morning. Evening she had the labor pain. She was shifted to the obstetrics department, and they did the lower cesarean section, and the child was beautiful. She came to me after 1 week and showed the baby, and afterwards she never came up for the follow-up of the aortic stenosis. And after 1.5 years, she came back only when she was pregnant again. So this is how our people are, and we have to educate that this bicuspid aortic valve can have stenosis, aortic regurgitation, and it has to be treated in time so that we have to give the best result. So this is a child who, this is the patient who had a previous stillbirth, and this time she was very extra careful. The moment the fetal movements reduced, she ran to the hospital, and then they saw that oligohydramnia was there, and then they did the cesarean section without doing the echo. So neither the fetal echo was done nor the previous echo was done. And then the child did not cry. So they put the patient on the ventilator. On the ventilator, the patient was shifted to me. And then, you can see that there is a pinpoint aortic, critical aortic stenosis. On one hand, we have a grown up lady with the pregnancy coming, and this is a newborn baby just 14 hours after the delivery. And then I opened with the 4 millimeter PTCA balloon, and the child, the x-ray improved like this. And not only that, the pinpoint aortic stenosis was opened up well. And then when the child came for follow-up, the child was running so much the mother could not catch him. So that is the result. But today, aortic balloon valvoplasty is being done in the intrauterine thing. Not only in US, even in our country, it is being done. So this is a 10-year-old asymptomatic patient referred for the evaluation of the continuous murmur. And then when I did the echo, you can see that something abnormal is going from the LA to the RA. So I could not make out what exactly it is. And then when we did the angio and the further echo, we knew that this was the LV to the aorta to the RA tunnel, and this tunnel was closed with the device. So this is 11-month-old child. This infant had again came with the continuous murmur, and when we did the echo, it looks as if aorta is split into two. So whether is a double aortic arch or whether it is a tunnel, one has to be very careful. And this patient, before closing, I did the echo, and here you can see that the extra cardiac portion comes into the RV, and then it is opening into the RV. So this was aorta to the right ventricular tunnel. So before closing, we did the coronary angiogram, and then we saw that the CT was done, and that showed a single coronary ostium. So here we were very, very careful because the coronary artery should not be closed when we are putting the device. But the tunnel was on the other side, and as a result, it was very easy. And everybody says that at the end of the tunnel there is a light. So here there is a light to the patient because there is a device at the end of the tunnel, and the patient made a complete recovery. This is how congenital heart disease can be treated. So this is a 11-year-old girl diagnosed as a rheumatic heart disease because she had a mitral regurgitation, put on penicillin prophylaxis almost for 2 years. And then when she was referred to me, I was surprised at the age of 11 years why she has developed such a severe pulmonary artery hypertension. So one thing that everybody should remember, that if you see the glistening endocardium or the glistening papillary muscle, it indicates subendocardial ischemia. The moment there is a subendocardial ischemia, you should go to short axis and look for the coronary arteries. And this was a Al-Kappa. So the anomalous left coronary artery was arising from the pulmonary artery. So this was operated, and she became all right. So this is a 10 years old child treated in West Bengal for tetralogy of Fallot. But then the child after 1 year, had developed congestive cardiac failure. Usually tetralogy patients never go into the failure, and I was surprised. So when we did the echo, I got the rarest of the rare case. The aortic regurgitation is always from the aorta to the left ventricle. But here you can see that the regurgitant jet is going from the aorta to the right ventricle. And that is the reason The systemic pressure is filling the RV, and as a result, the patient is in the congestive cardiac failure. So, overriding aorta was not corrected properly. The VST was stitched in a wrong way, and that's how we know one cusp was the right coronary cusp was on the RV side, and the left was on the RA side, and that's how the registration was there. This patient surgically corrected, but unfortunately, he came back after 1 month, and then, to the shock of my life, you can see that multiple vegetations were there, and this is how we know we could not save the patient ultimately, despite our best effort. So that's how we know sometimes the congenital heart disease, whatever we try, the infection is the number one enemy for any surgeon. So this is a 2 years old child presented with a history of easy fatigability and cyanosis and crying from birth. But there was no murmur. There was nothing to say that the patient had any cyanotic. So when you have no murmur, but the cyanosis is there, think of two things. One is the pulmonary AV fistula, and other one is the systemic anomalous venous drainage. So this patient, there was a cardiomegaly, and you can see that all the hepatic veins and they were draining into the LA. And apart from that, you can see that it is a situs ambiguous, and LA and LV are dilated. RA, RV are small in size. So they are dilated because all the systemic venous drainage is into the left side. So not only the pulmonary venous blood, but also the systemic venous blood is coming into the left side. So here you can see that there are three jets coming, and this is the modified view where you can get the all the veins draining into the place. And this patient had to go for the early surgery because this cannot be treated otherwise. If there is a single left superior vena cava draining into the uh, left atrium, we can put the device and close. But if all the veins are draining into the LA, it has to be corrected surgically. So this patient underwent the computed tomography, and that also showed the problem. So this is another case, 2 years old cyanotic boy diagnosed to have as the VST with the pulmonary stenosis. And the four chamber view showed the very peculiar, I don't know, there was a split in the interventricular septum at the base as well as in the apical portion. And I was able to not make out. So whether there is a VST or not was a dilemma. And apart from that, to open up the pulmonary stenosis with a balloon, we have to be careful whether there is a Swiss cheese VST. Otherwise, we'll be converting VST PS into the VST with the pulmonary hypertension. So what we did was we did the cardiac MRI, and that showed that there is a pulmonary stenosis, but there is a double chambered RV. So this is the apical chamber and this is the infundibular chamber, and we were not sure whether there is a VST is there or not. They were not able to tell us properly. So we went to the cardiac CT, and the CT showed that there is a double chambered RV and then the pulmonary stenosis, and then they said there is no VST. But to be sure, I did the 4D echo. Here you can see that the interventricular septum is intact. There is no VST, and you can see that this is the thick thing which is dividing the right ventricle into two chambers. And then we did the balloon dilatation, and literally the 4D echo is like, seeing into the heart like live. In fact, even the surgeons cannot see like this because they would have done the cardioplegic solution and then the heart is not beating. But the 4D echo is so fantastic. You can see the split here. You can see the mitral valve, which is a tricuspid valve, and the split interventricular septum. And then I did the balloon dilatation. The saturation improved and the child became much better. And then we referred for the surgery for the double chamber RV. This is the 25 years old male presented with the history of the chest pain, and something peculiar was there. That is, there was some channels were there on the RV side, and then when we saw that there is a glistening endocardium indicating that there is a ischemia. And this is how the RV side, there are multiple channels. And when did the short axis, you can see that the right coronary artery is dilated, and then it is draining into the main pulmonary artery here. And that is the right coronary artery to the pulmonary artery fistula. So coronary AV fistula was the thing. And this is how we know the patient went for the surgery and made a complete recovery. So this appears very funny, as if there are three chambers. No, this is the congenital heart disease where there is a submitral aneurysm, and this aneurysm was closed with a device there, and that's how we can treat. Even the most complex can be treated. So interventions are safe, effective, and attractive alternate to the surgery, and they can be complement to the surgical treatment, or they can be independent also. So where there is will and skill, there is a way. So even the most difficult things can be done, but there is no chance for you to get distracted. Once you get distracted, and that can be a disaster in the cath lab. So this is how we know, when I did the first device closure, the first one to do in the Kuala Lumpur, this was on the mega screen. And this is how we know the interventions can be done. This is Bob Anderson and this is Richard Van Pra. Both are, what to say, the legendary people in the congenital heart disease, in the cardiac anatomy. And they are the fantastic people, and they have given so much of knowledge to us. And Bob Anderson once he said, uh, we have laid the foundation, Vijay. You young Indians have to build the castle. And that's how, the whole world is looking at the Indian cardiologist to make the do the better quality of life to the patients. And today, the pediatric cardiology in India has advanced so much that we are doing the top class, world class work. Thank you very much for the kind and the patient hearing. Thank you. Can I have the questions? I think I have finished exactly in 30 minutes.
Yes, ma'am. Yes. Just a minute, ma'am. Just a minute.
Any questions in the
Yes, ma'am.
question box, chat
Yes,
box?
yes, yes, ma'am. Ma'am, there are questions, ma'am.
Okay.
Just give me a minute. Yeah, ma'am. Dr. Ramji wants to know, is a blockage of 40-50% in CG and CT angiography common in a woman over 60 years old if the blood pressure is controlled with medication?
No, he's talking about the coronary artery disease, right? Not the congenital heart disease I spoke. See, it is not the 60 or the 70%. In fact, now they have the intra thing, the IVUS can be done to calculate whether it is significant or not. And then it can be angioplasty can be done. Okay.
One more query is there. What are the most common challenges faced in managing arrhythmias associated with congenital heart defects, and how can pediatric cardiologists optimize the treatment strategy?
Okay. See, usually the corrected transposition of great arteries, they have the accessory AV node. And as a result, in the same day, they can have the bradyarrhythmia or tachyarrhythmias. So now we know that accessory channel can be ablated. So the best way to thing is the electrophysiology person has to evaluate whether there's an extra channel, the arrhythmia is due to that, or the post-operative, when in the past they used to the RVotomy, the right ventricle they used to cut, and as a result they used to have RVBP and arrhythmias. So here the drugs can be used or ablation can be done, and the both things can be continued.
Right, ma'am. Thank you, ma'am, for answering the query. So, with that, I would like to conclude our session for today. But, ma'am,
Thank
before
you.
that, I would like to thank you on behalf of the IGCP group for taking out your valuable time, making such a beautiful presentation, and answering all the queries of our audience. So, thank you, ma'am. Thank you so much once again for joining us. Thank
Thank you
you.
so much. Thank you.
Thanks to all the audience for joining and making the session and a successful one. Thank you. Thank you, everyone. Thank you so much, ma'am. Thank you. It was a pleasure having you.